Today's episode of Vital Voices is brought to you in part by Oak Tree Medical Center, Colina Insurance Limited, and Vala Security. Welcome to Vital Voices, where we dive into the topics that shape our health and well-being. I'm Alexis Burrows, and today we're exploring women's hormonal health across the lifespan. Hormones are often called the body's chemical messengers, influencing everything from mood to metabolism, fertility, and beyond. Joining us is the esteemed Dr. Carmen Cartwright, a leading expert in hormonal health. Together, we'll unpack common conditions like PCOS, the changes women face during menopause, and the role of hormone replacement therapy. Whether you're navigating these changes yourself or supporting a loved one, this episode is packed with valuable insights. Let's get started. So, welcome back to the show.
Thank you.
We are glad to have you back. I know we had you on probably a few months ago now, talking about diabetes. And so today we are actually starting a two-part series, so to speak. We're discussing women's hormonal health in this episode, and then we'll come back around and discuss men's hormonal health separately. So I guess to kind of start at the ground floor, what role do hormones play in the overall health of women?
Excellent question. And to be truthful with you, that's a pretty broad question to think about in terms of the multitude of hormones that guide processes within our bodies for both men and women. Mm-hmm. So I'm happy that, as you said correctly, there's going to be a series dedicating time to both sexes so that we can delve into the hormones that are specific to each sex. But if, for instance, we even, in the understanding of time frame, you could think about thyroid hormone, right? Thyroid hormone largely controls our metabolism. Adrenal-based hormones largely control our blood pressure, overcoming infections, our fight or flight hormone, that if you're swimming in the ocean and there's a bull shark, you're like, boy, I better get out this water. Mm-hmm. That's the hormone that helps you. Mm-hmm. And that's just a couple to name them, right? But if we're looking specifically at female-based hormones, we'll talk about the fact about estrogen, progesterone, prolactin, and testosterone. That's a big thing that a lot of patients don't realize, and the community doesn't realize that for both men and women, we have both. It's just about the balance and the fact that for we as women will typically expect to have more of our female hormones and a smaller amount of male hormones. But basically, the biggest thing for female-based hormones, how it affects our life and in our health, in our lifespan is, allowing us to carry a child, mm-hmm. feed a child, if that's our wish in our lifetime, and if it's not, that's okay. That's your personal decision, right? Mm-hmm. It also, estrogen specifically helps to protect our bones, keeping them strong, allowing us to achieve our adult height and our adult bone mineral density in terms of our peak bone mass. Mm-hmm. And it does actually help to reduce cardiovascular disease earlier in life.
Didn't know that.
In that we'll see, as women age and we lose our estrogen, we start to talk about menopause, oftentimes we will actually see more cardiovascular disease, which you also have to say, okay, well, part of that probably is also the natural aging process anyway. Right. But those are the big things in terms of how female-based hormones affect our female health over our lifespan.
And so what are some of the key hormonal changes that women experience as they go from, being a baby, a kid, adolescent, adulthood, and then as they get older, what are some key things to look out for?
Sure. So obviously the big things we think, again, if we're thinking about sex-based hormones, mm-hmm. again, we're talking about females coming to men in the next discussion, is puberty.
Right.
I will say one up that men have over us as women is we are born with the eggs we will ever have.
Right.
Whereas men will continue to, every couple of months, make new sperm, and they can go until their 80s. Whereas for us as women, we're born with what we have. So typical age for puberty for girls is between 8 to 13. It starts usually with breast bud development. That's the first thing we see. And then usually about 2 years after that, you'll see the actual onset of the menstrual cycle itself, along with pubic hair development. During that time, apart from seeing those obvious physical changes, you'll also see linear growth in terms of patients and children achieving their height. You'll also see that for girls more so it's going to be more fat mass accruement as opposed to boys, which we'll talk about when we talk about men. That's more lean body mass that they accrue during puberty. And a big thing that, questions that we'll sometimes have as endocrinologists is, well, is it too early? Is it too late for my child? Because again, we talk about 8 to 13 as a typical age range.
Yeah.
A big way that you can look and try to understand is also look at your family. So if, let's say you have, a daughter, and you're trying to understand when this is likely going to happen, look at mom, look at any sisters to give you an idea. Genetics play a role. Again, that goes back with family history. Our lifestyles play a role. There's been some evidence to say that stress can actually induce early puberty. Obesity has been linked for girls for early puberty, not as much data for boys.
Okay.
And then once we go through puberty, then the majority of our life as women is reproductive age, allowing us again to, have this orchestration where the big boss pituitary gland in the brain, and I like to call it the big boss because it basically sends out signals to all the other endocrine glands, except for a couple, to tell them what to do.
Okay.
So it creates this orchestration that says, okay, ovaries, I need you to build up this lining in the womb that if an egg is fertilized, it can hold an egg. And if an egg doesn't get fertilized, we shed the lining. And then we repeat the cycle every month. And that's reproductive years. And then typical age for menopause is around 50 to 51. So in the years leading up to that, there's some data that suggests around 4 to 5 years leading up to that time, women will start to see changes, giving them the idea that, hey, menopause is probably coming. And then that would be the next stage that we see is menopause and then postmenopausal time in our life. Yep.
Okay. I know that here we have a lot of women that have challenges with polycystic ovary syndrome. Sorry. Is there a connection between that and hormones? And how does that kind of play a role into the hormonal development? How does it all work?
Excellent question. So PCOS is a spectrum of disease. I'd like to start off with that. In that not every person is going to look exactly the same, but might fit into a classification to be considered to have PCOS.
Okay.
I also like to put it out there for women to know that if you are seeing a physician and they're talking about PCOS is actually a diagnosis of exclusion, in that we have to make sure other things and other entities, other medical problems are not there to confirm that it is in fact PCOS.
Okay.
But usually in puberty, again, breast bud development and then menstrual cycle, in the first few years of a girl getting her menstrual cycle, it can be irregular. But if that irregularity extends beyond the first few years of starting their period, that can be a hallmark of PCOS.
Okay.
And we're talking about women who will skip periods for months on end. Because a usual typical acceptable range for a cycle, and a cycle for ladies to know is you're counting the first day of a bleeding to the next first day of a menstrual bleeding is anything 21 to 35 days.
Okay.
So if you're going beyond that, and that's usually what you'll see in PCOS is they go with longer lengths of cycles and missed periods. That is a hallmark, but that's not the only thing that can cause it. Thyroid dysfunction can cause it. Severe stress, people who do marathon running, Olympians who have major stressors on their body where they have rapid weight loss, for instance. We think about that as an evolutionary protector, that if you suddenly have a lot of fat mass loss, is it really the right time for you to hold a baby? So then your big boss pituitary and really the hypothalamus, which is even higher than that in the brain, says, hey, maybe we don't need to have these signals sent down to the ovaries right now.
Interesting.
In any event, let's go back to PCOS. I apologize, I digressed for a second. So PCOS, spectrum of disease, more often irregular cycles that are extended beyond just the first few years of menses starting. You can have polycystic ovaries on imaging. That is not required to diagnose someone with PCOS.
Okay.
And sometimes that will actually be what patients will tell me. They say, oh, well, my doctor said I had a bunch of cysts on my ovaries and I was told I have PCOS. I'm like, it could be, but also depending on where you are in your cycle, there are other conditions that can also create that on imaging and not necessarily be PCOS.
Yeah.
And then the third thing that we look for is evidence of excess androgen, excess testosterone. So again, I mentioned earlier that for all men and women, we have both male and female hormones. But what happens in women with PCOS spectrum is they have more than enough female hormones. So again, they can build the lining. They can do what they need to do if, they were to harbor a pregnancy. But the excess male hormone will sometimes stop them from ovulating and will also cause them to have physical presentations of excess male hormones. So male pattern hair growth, chin, chest, back, legs, and acne. It can be a big other portion that we will see. And often we think of PCOS as being linked with insulin resistance, and we see more often that it's heavier set individuals, obese individuals, but there are also lean patients that can have PCOS, and that's why I like to say it's a spectrum of disease.
Right.
Yeah.
Because I guess there's a lot of potential factors involved. What are some of the primary causes of PCOS?
So to be truthful with you in terms of the cause, it's that imbalance in that you're having just a little bit too much male testosterone being made from your ovaries. There are some adrenal androgens, so male behaving hormones that are created and released from the adrenal glands that play a role. And that's one of the things we actually look for when we're trying to diagnose with someone with PCOS, is to confirm, is this truly PCOS or is there something coming from the adrenal gland?
Right.
And that's what causes that imbalance that can block their ovulation.
Right. That's why you said it's exclusionary. You have to rule out other things before you come to that conclusion of PCOS.
Yep.
What impact so if someone does actually have PCOS, what impact can it have on their fertility, on their metabolism? How does that, because obviously I know all of those things kind of play together.
They do.
So how does that work?
Excellent question. So, patients with PCOS, again, insulin resistance is highly tied to PCOS.
Okay.
So when we did our diabetes talk, we talked about type 2 diabetics having insulin resistance. So patients who have PCOS are high risk for diabetes development.
Okay.
And conversely, patients who have increased fat on their body, obesity, overweight, the fat cells themselves increase insulin resistance. Insulin resistance in a patient with PCOS can block ovulation. So it's almost like a vicious cycle in terms of we need to control both aspects. But insulin resistance is the biggest metabolic derangement in patients with PCOS. To the point that if we can, and one of the ways that we try to improve PCOS outcomes is actually trying to reduce insulin resistance. And there are ways we could talk about, we do that in a second. But you'd also ask about fertility. That's actually a really big question I get from most women with PCOS. They're worried to say, okay, how's this going to affect my probability of having a child?
Right.
And I tell patients that if we can get your PCOS in a better state where you're then having consistent cycles, we remove that irregularity and we say, okay, well, that's suggestive that you're starting to ovulate again. Most women with PCOS will need some assistance. But it's not necessarily to the full-blown aspect of in vitro fertilization.
Okay.
So it's often a medication that can push them to ovulate, and then they have timed intercourse with their partner to increase the likelihood of getting pregnant. But I do see women with PCOS getting pregnant. It happens. Sometimes even when they're not planning it, because they're so used to the irregular cycles that
you miss it and you don't really
exactly
realize.
They said, oh, I didn't think it was happening because I'm always irregular, and then boom, it happened. But oftentimes that'll be, for the majority of patients, if they need assistance, that would be the extent. Can I say with 100% surety that there has never been a woman with PCOS who needs IVF? No, I can't say that, right? But it's more often medications like letrozole or Clomid. They mimic the signals that normally come from the brain, again, that big boss pituitary gland, to tell the ovaries what to do. And we hyperstimulate the ovaries to push out more follicles, to release more eggs to ovulate. And then we do timed intercourse. Okay.
Yeah. You mentioned earlier irregularity, and I know you talked predominantly about the timing of the cycle. Does PCOS present with any other sort of like irregularities? Like, is it extra bleeding or
excellent question,
extra pain, things like that?
Pain, not typically. However, there can be abnormal bleeding when the bleeding finally happens. So for women with PCOS, again, they can build the lining, their body's preparing, but then they don't ovulate. So then there's no signal to the brain to then cut the hormone levels down and let the lining come out. Exactly. So if, let's say, they go 5 or 6 months without a period, and then they finally get a signal to shed, they've held on to a lot of lining. So they can then have a much heavier period during that time.
Okay.
And that can be troublesome for patients, obviously, right? You go from one extreme to the next.
Right. You go from nothing to a whole lot.
Exactly.
Gotcha. So you started to touch on treatment. I know the female reproductive system is an interesting one when it comes to treatment, because there's so many different variables of what can be going on in the system. But when it comes to PCOS, what are some of the most effective treatment options? Is it something that requires surgery? Is it just medication? Is it lifestyle changes? What kind of fits into that spectrum?
Excellent question. So I would say surgery, not typical.
Okay.
Unless whenever we look at fertility factors in a couple and something's happening, even if they may have PCOS, does that mean they couldn't also have fibroids? They could.
Right.
Someone could have, that particular
combination.
Exactly, combination. But if it's PCOS itself, then generally our goal is to push the body to have a regulated cycle to reduce insulin resistance. And we can do that in several ways. But as we do, or as we should as physicians do with any patient we approach, is we need to understand them as a whole. We need to look at their background, their other health concerns, and what is their goal. So let's say if I have a young woman who has PCOS, irregular cycles, and a big concern for these irregular cycles, if they go months and months and months without menstrual cycles, again, that lining is building up. That lining can become abnormal. It can be at risk for abnormal changes, at risk for endometrial cancer. So that's a big reason we want to shed it and not let it stay. But let's say she's not ready for pregnancy, then birth control tablets in terms of combined hormonal contraception, so estrogen and progesterone. Because then what you do is you allow the big boss pituitary gland and the ovaries to take a backseat. And you just say, look, I'm going to orchestrate this now from the outside.
Right.
And doing the combination pills helps to reduce the testosterone levels as well.
Okay.
But if they're wanting to get pregnant, then obviously that's not the answer. Right? So you'll be like, nope, then this is not what we're going to do. So if let's say someone instead, one can't have birth control tablets for different reasons. Patients with certain migraine types, uncontrolled blood pressure, history of blood clots, they can't have birth control.
No, too much risk.
Exactly, too much risk. Then you say, okay, we can use things like metformin. We talked about metformin when we did our diabetes talk, and it helps to reduce insulin resistance. So even in a non-diabetic PCOS patient, we can use metformin to reduce insulin resistance to try and allow them to ovulate. And it works for some women. You also have some information about the inositols. So some patients ask me about D-chiroinositol or myo-inositol. These are actually supplements. As of the latest guidelines for PCOS care, there's not enough data for us as physicians to say, yes, take this type and this amount. However, we have found that it can help with insulin resistance, and thankfully it doesn't appear to harm patients. So if patients tell me they want to give it a try, I go down the road with them and we say, we'll give it a try. And then weight loss is a big one. So if, let's say, you are a PCOS spectrum patient that is obese or overweight, weight loss can also make a difference. Because again, it's reducing that insulin resistance and might allow you to have resumption of ovulation and regular cycles.
Yeah, I always find it so interesting how so many of the conversations around health right now, a bigger part of the treatment option seems to be lifestyle changes and things in that space. And I find it interesting, no matter who I've sat down with and what area of health or illness we talk about, that always seems to be a factor, which is interesting to see how that is, kind of building up in the background as another arm and another a way to help people manage a lot of these things that they're going through. So you mentioned, obviously, two major changes during a woman's lifespan as it pertains to hormones. One would be the onset of puberty, and then another big one would be as they transition into menopause. And we're actually planning to have a much longer conversation about menopause with Dr. Agatha Mackey in a little bit as well. But I wanted to kind of get your input from the endocrinologist standpoint, because it's funny, my wife has been in a lot of different spaces recently and having conversations with different women who are either just about to go into menopause, who have been through menopause, and she's found it fascinating how little women seem to understand about the process. So can you kind of just explain for, I guess, especially our female listeners, maybe for our male listeners as well, so they can learn how to navigate
Right,
but,
yeah.
What happens as a woman starts to go through the process of menopause?
Sure. So, and I'm happy to have that conversation because I do agree with you. I think that not enough conversations are had about menopause, about how to manage menopause. And a lot of times women just deal with it, right? And when I have conversations, like let's say patients see me for diabetes and by chance they're in that age range of typical age for menopause, I'll have a discussion with them because they will just live with the symptoms and say, I guess this is just my plight.
Right, like it is what it is.
Whereas men, when we talk about the men video, men within 5 seconds of sitting down in the chair, if they have a concern in regards to their sexual health, they're not afraid to talk about it.
Top of mind.
All right, so going back to what's actually happening in menopause. So as we talked about earlier, women are born with the eggs that they will ever have.
Mm-hmm.
Even before we hit puberty, we've lost eggs. The eggs are there, but they need to mature. As we go through reproductive age, eggs are selected, they mature, they're released, they're fertilized, or they're not.
Mm-hmm.
And as we get closer to menopause, that egg count is going down. So the ovarian reserve is going down. And with it, our estrogen production from the ovaries. So as the estrogen production goes down, that actually is what is signaling menopause.
Okay.
Menopause itself is when a woman has had 12 months of no menstrual cycle straight, and they're around the typical age. So again, typical age in Western society is around 50, 51.
Okay.
However, some women can go through it in their early 40s.
Mm-hmm.
Younger than 40 is considered premature ovarian failure, in that we need to find out why did it happen so early.
Right.
And some women may be unlucky that they could be in the 5% that go even beyond age 55.
Mm-hmm.
Again, a way you can look at it is look at your mom, look at your sisters to
Right.
have an idea of when might that happen. So again, what's happening is ovarian reserve is coming down, estrogen levels then plummet, and boom, we're in menopause.
Right. I realized when you mentioned it earlier, I had this question. Is there like a typical count of, because you said women, they're born with, just whatever their complement of eggs are.
Right.
Is there an average number of what that is?
You mean like when they're first born?
Yeah.
Like around millions of eggs. I
Right.
think 11 million is around the latest data I saw from at least one source.
Right. Nobody has a million periods in their lifetime, obviously. So I guess a lot of shed happens before puberty?
Mm-hmm.
Interesting.
Yeah, a lot are lost. Because again, the eggs are there, but they haven't matured yet. Because what can also happen as we get closer to menopause, even though we may still actually have some eggs sitting in the ovaries, they are no longer signaled to mature. Because also the signal from the big boss pituitary gland starts to get a little bit less. But one of the ways we can actually diagnose menopause, although truthfully menopause is a clinical diagnosis, you don't have to do a blood work to confirm it. Unless there are certain instances, again, younger age, if they're having other symptoms, first thing we always check is to make sure you're not pregnant. Because I have to warn women, when you are going through this perimenopausal stage, irregular cycles, and we'll talk about all of the symptoms, women, if they're not protecting themselves, can still get pregnant. Because 1 month you could not ovulate. You could skip a period for 3 months and then boom, you ovulate and you could get pregnant. So protect yourself if that's not in your purview at like 49.
Women really have a rough plight, boy. That's tough.
We take it in stride.
Right. So like you said, if you think about it, if you go 3 months and you're around the age range, you could really look at it like, well, I guess this is where we are.
Right.
And then surprise pregnancy at late 40s, early 50s sounds like psychosis.
Yeah.
You started to mention symptoms. What are some of the common symptoms that women face? And then how do they manage them? Because I always like to laugh. I look at menopause as men on pause. Because it seems like, because you hear, obviously you see so much stuff in media and movies and TV, and you get this generalized idea.
Right.
Moodiness and all these sorts of things. But what are, from an actual physician's perspective, what are some of the common symptoms that women face and how can they manage them? Yeah,
so the biggest ones that start will be irregular cycles. So again, we said 21 to 35 days is a typical cycle length. But coming up to the years, and again, 4 to 5 years even before they go to their last menstrual period and then do the 12 months of no period, things can become irregular. So the cycle lengths can get longer and longer. But they can also have irregular bleeding in that they can have shorter or longer cycles. And again, you can ovulate 7 months, not ovulate other months. So be careful in that regard. And then hot flushes. Hot flushes are the other big symptom that patients can have. The problem with hot flushes is they can be disruptive to people's lives. And the way that women often have described it, when I hear it, is they talk about it as like a central heat that comes from the inner part of their body, spreads out to the outer portions of their body. They often will perspire. It lasts for a couple of minutes, and then they go the opposite direction. Some people have chills. They start to get cold. They suddenly have to get like a blanket or a jacket to put on them as they're cooling down. And some people could even feel anxiety afterwards.
Oh boy. And
with the hot flushes, they can happen any time of day, but a lot of them actually have predominantly at night. So that can also lead to sleep disturbances.
Like your night sweats and stuff like that.
Exactly. Now we have to be careful though. I tell ladies, if you ever get into a position where you're having night sweating episodes and these heat episodes. And it's not just a couple of minutes. It's suddenly, fully drenched in sweat, having to get up to change your clothes. That can actually be other entities like cancers and like blood disorders.
Right.
We have to be careful. Thyroid disease can cause that. So we have to be careful in terms of automatically lumping it as a hot flush, depending on how it's behaving. And then another large one, so irregular periods, the vasomotor symptoms, which is the hot flushes, sleep disturbances, mood changes, anxiety and depression are big, especially in someone, if they were already prone to depression even before menopause, they're more likely to be at risk for that to develop. And also decreased libido. Although that's pretty variable in that the ovaries will actually still be making testosterone. So the estrogen levels are going down. Testosterone is still there to some effect, but some women can get to a point of also testosterone deficiency. Currently, guidelines, and when we talk about hormone replacement therapy, there are no specific guidelines currently to say that we should be giving women testosterone for sexual dysfunction. But some of my colleagues do it. I might consider it depending on the patient, and we talk about it in terms of the risks and so on, but it's not data driven yet to say that we should be doing that. And then lesser understood, lesser data like supporting these other symptoms. Like some people can have joint pains. Some people can have forgetfulness and brain fog that they see suddenly happening. Not that we have a clear connection to say that happens to all women, but those are the biggest symptoms. Yeah.
You mentioned earlier on that, you do have issues like bone density and connections like cardiovascular disease as women go through menopause. Are there any other areas in terms of the long-term health that menopause impacts? What can women expect in that way?
I mean, those two are the largest in terms of data-driven information.
Right.
So for the 2 years leading up to a woman's last menstrual period, and for the year in that first 12 months right after their last menstrual period, that's actually the biggest loss of bone mass. And that's why bone density scans, if we ever do talk about osteoporosis, bone density scans are really important. Let's say if a woman goes through typical menopausal age, 50, 51, 65, bone density scans are supposed to be happening so we can assess your bone health. And then, there is some data, and for some women, we might consider estrogen replacement to help with bone health. But there's so many other better options for bone health that we don't necessarily go to that alone. Especially there might be reasons that they can't be on hormonal replacement therapy in terms of safety for them as a patient. There is, again, some data suggest increased cardiovascular disease as we go through menopause because estrogen can have a protective benefit. And it's more so derangements in our cholesterol in that we're seeing more of the bad cholesterol, more LDL cholesterol, and less of the good HDL cholesterol that helps to protect us. There is some other entities that is being suggested, but again, limited data, more so observational data to say that it could be other long-term effects, so worsening osteoarthritis, dementia or cognitive dysfunction. Although when we look at that specifically, and Women's Health Initiative, when they did their studies looking at hormone replacement therapy, they didn't actually see an improvement in that specifically when women were treated with estrogen in terms of the cognitive dysfunction.
Right.
And then, you can see skin changes. Again, observational data that collagen production is also decreased in estrogen deficiency. So more wrinkled skin and things of that nature you can see as well. But the biggest ones would be cardiovascular and bone health for sure.
Okay. You started to touch on this a little bit. Our next section is going to talk about hormone replacement therapy. What is hormone replacement therapy and how can it help during things like menopause or other, hormone related issues for women?
Okay. So if, let's say, you have a woman who has premature ovarian failure, and we were talking about that being younger than 40, or let's say you have a patient who had to have a hysterectomy, and at the time, they also need to have both of their ovaries removed. Because if a woman has only her womb removed and the ovaries remain, then she should typically go through menopause around the same age as she would have done otherwise. Although there is some data coming out to suggest that it might be a little bit earlier. The only issue is for those women will never be able to use their period stopping to really know when they went through menopause.
Right.
We can go by symptoms.
Mm-hmm.
And in that instance, you might check the signal that comes from the big boss pituitary gland to give you a better idea, because again, we can't use menstrual cycles. But to go back to it, if you have someone who has premature ovarian failure, they should automatically be given hormone replacement therapy because they're already going to be at a higher risk because they're going through that earlier,
right?
10 years earlier than you would normally anticipate them to.
Right. Especially when you consider the potential issues like with bone density and cardiovascular health.
Exactly.
You don't want that starting at 40 unnecessarily.
Right. Exactly. Gotcha. Exactly. And then otherwise, let's say you have a female that goes through menopause at the typical age. Then again, I go back to it. You have to talk to the patient as a whole, look at their comorbidities, what other health issues do they have going on, and what is the goal, and when are they meeting you?
Right.
In that, again, going back to Women's Health Initiative, that was a study looking at estrogen replacement therapies and how it actually improved or didn't improve outcomes for women, looking at the side effects and so on. There was more data for older patients in terms of risk of actually causing more side effects that led to a change in how much hormone replacement therapy was actually being prescribed in years past. To the point that in the past, hormone replacement therapy, let's do it. Women's Health Initiative happened. There was some data that came out that said, okay, maybe we're hurting them. And people, physicians got nervous and they stopped prescribing. But if we look at the data better, it shows that if you have a woman who is younger than 60, and in the first 10 years of going through menopause and having troublesome symptoms, vasomotor symptoms, we talked about the hot flushes, the irregular cycles are going to end at some point because you're already at that point, right? 12 months of no period. We're not worrying about that. But the genitourinary symptoms, in terms of painful intercourse, vaginal dryness, itching, feeling like they have a urinary tract infection, but they don't actually have one, are reasons to then consider hormone replacement therapy so that you can help to alleviate those symptoms and improve their quality of life. And for those patients in that class, again, less than 10 years since onset, younger than 60, there has been more benefit than risk in terms of helping with their bone mineral density and the cardiovascular health, but importantly, managing the symptoms.
Right.
Yep.
So if you have someone who is, I guess, in their early 50s and they want to try and I'll ask the question, you could let me know if it makes sense. But if they're late 40s, early 50s, and they're wanting to use hormone replacement therapy as a way to push back menopause in order to preserve the potential to be pregnant, to get pregnant, for example, is that a space where that's not what it's used for?
No, that's an excellent question. Unfortunately, it's not. So whenever we do, and we'll talk about that, especially in the male topics, when we talk about how does, low male hormone affect fertility and so on. Unfortunately, when we give synthetic hormones from the outside, again, we're shutting down what the brain is telling the ovaries or the testes to do. So you're no longer endogenously making your own estrogen or testosterone in men. And again, by the time women hit menopause, their ovarian reserve is almost zero.
Right.
So unfortunately, if a woman wanted, let's say you had a younger patient in their early 40s going through the changes that appear like menopause, and they say that they want to have a pregnancy, then hormone replacement therapy
is not it.
Won't be it. But with reproductive endocrinology, because we do have colleagues who specialize just in that, they will help, maybe they have to do egg transfers. Maybe they need to have a surrogate egg, different things that even though their womb might be able to hold and, foster a baby.
Right.
They may not have what they need to actually make it happen. So that would be something they would have to think about. That would be IVF.
Right. I got you. Okay. All right. So I think you started to mention this a little bit. Well, what are some of the benefits and the risks of hormone replacement therapy?
Okay. So benefits, improving quality of life. Again, especially for women who are having really disruptive vasomotor symptoms that lead to sleep disturbances, mood shifts, and then the genitourinary symptoms. Again, the vaginal dryness, painful intercourse, feeling as though they have a UTI, but they don't have a UTI. And there are different ways that we can treat it. So hormone replacement therapy comes in vaginal creams, vaginal suppositories, So if, let's say, I have a female that has predominantly those symptoms, they don't really get bothered by the hot flushes. So like, doc, that happens once a day. I have my fan, I'm straight.
Right.
But every time me and my partner want to have intercourse, it's uncomfortable. I constantly feel itching and everything just doesn't, just doesn't feel right. Then we'll say, okay, well, maybe that's a better option for you. Versus if you have someone who's having more of those hot flushes, then you say, okay, maybe we need to go more so for either transdermal patches. So estrogen can come in patches. It can come in tablets. And then the other thing we have to think about is if we have a female that still has their womb intact, we have to protect their womb. Because the same way we talked about earlier with PCOS patients, if they constantly have estrogen, they have more than enough female hormone to build the lining, but it's never coming out, we can increase their risk for abnormal changes in the cells in the womb. So they also have to take a progestin. When you do the combination of estrogen and progesterone or progestin together for hormone replacement therapy, you can sometimes have bleeding like a period. So some women are like, why are we going back to this? But not always, because you also have the patches that can be lesser amounts. So it might just be regular spotting here and there. But again, you talk about the benefit and risk, right? In terms of for a woman who may be having really troublesome symptoms, and I say, I'll take that back. I will go there, right? Now, what are the risks? So VTE, so venous thromboembolism. So in terms of clots, that's a big one. Stroke, gallstones. If someone has like an underlying unrecognized breast cancer, that can make it worse because some breast cancers are actually estrogen receptor positive in that estrogens can worsen breast cancer. So that would be one of the contraindications, like who cannot get this in terms of if someone's had a history of breast cancer, a history of a blood clot in their leg or their lung that was unprovoked, that it just happened, or they have a propensity to that. Patients who have had strokes, significant heart disease. Again, you'll have the discussion with the patient and say, okay, what if you had a heart attack 5 years ago? You might still say, this is increasing your risk. But it was also a remote event. Depending on how well the coronary artery disease is managed at that time, could you reconsider it? And then I would say, if a patient has unexplained bleeding issues, so let's say that they've gone a full year with no menstrual cycle, and then they start spotting again, and they're not on any therapies, that should not be happening. They have to get that investigated first, because we can also make that worse with hormone replacement therapy.
Yes, there's a lot of things to consider. It's come across in our conversation that a lot of these things are not a one cap fits all. It's very situation specific. So for women who either because of some other comorbidity or condition that they're not able to, or it's not safe for them to take HRT, or for those who just choose that that's not the road they want to go, are there alternatives to hormone replacement therapy for women? Excellent question.
There are. Because there will be some women, as you rightfully said, let's say if you had someone who had a breast cancer history and we don't want to take that chance. Or they just had a stroke, 6 months ago, and we don't want to take that chance. So you have non-hormonal treatment options. The only one currently FDA approved is low-dose paroxetine or Paxil. It's an antidepressant, anti-anxiety medication at lower doses that predominantly helps with the hot flashes. The hot flushes, that can make the difference. You do have some data about medications also like gabapentin, which are actually nerve-based medications, and pregabalin that might have some benefit, but that's completely off-label use in terms of that's not approved by the FDA. So again, that's another discussion you have with patients. There can also be sometimes, especially for women who have predominantly vasomotor symptoms of hot flushes. So sometimes we'll counsel ladies, which I think doesn't really make a difference here for us, wear layered clothing so that when you have a hot flush, you can take pieces off, cool down, put them back on. But we already live in a hot climate where you're not wearing multiple layers.
It's just hot all the time, so you can't just be like, just go
just take it off. Yeah. Exactly, no. Spicy foods, alcohol can actually make hot flushes worse. So sometimes we'll say try to minimize those things. Then you talk about for women who may be having more of those genitourinary symptoms. I tell ladies, I said, look, again, if they're not necessarily a candidate for oral therapies or the patches, most oftentimes we can still consider the creams, at least for those symptoms, because it's going to have less systemic absorption into the bloodstream. But if they're even nervous about that, you can do vaginal moisturizers. You usually find them in the same aisle as personal lubricants that are used for intercourse. I have not had a good response in terms of people finding them over the counter here, but I'm sure when you guys talk with Dr. Mackey, she and I have talked before, and she usually brings or has access to some here locally.
Okay.
I have heard some OBGYNs talk about coconut oil as like one of the options that you can just find in the food store. And again, this is just to help to replenish the tissue so that you don't have as much of the atrophy. So what happens again down at the vaginal level is that the tissues start to shrink and things start to get tighter and drier and can again lead to that discomfort. But then I also tell ladies, have an honest conversation with your partner. Don't let them get in their feelings, and use lubricants during intercourse. This should still be an enjoyable, occasion for you and your partner. Don't be afraid to be honest about it, and to use those things. Okay. And then there is some data about cognitive behavioral therapy. Truthfully, I will leave that to my colleagues to say if they found that to be really helpful. Okay. I do get a lot of questions from women about like black cohosh and different supplements. There's not enough data to say that they actually make a difference. Okay. I tell ladies, if they want to try it, we can try it. We just have to make sure it doesn't interfere with any other medications that you might be on, and you can see if it makes a true difference. Right. But there's not enough data to really support that. Gotcha.
I feel like we need a disclaimer about that coconut oil, though. I don't think it's just any and every coconut oil that you find in the food store.
I would say it's also not for insertion. It's just for the exterior.
Yeah, tread lightly.
Tread lightly, right?
Consult your physician. All right. You mentioned earlier, in a couple of different spots, the impact of these hormonal changes on mental health. So, potential issues like anxiety and depression, especially for those who may have already had a history of it. What support systems or treatments are available for women as they go through these different changes? Because, I imagine it's a lot. I feel like just as a man listening to the conversation, I feel like this is a lot more than what men have to deal with. So it's like in terms of in this hormonal space. Yeah. And maybe I'll find out differently when we have the other part of this conversation.
I hear you.
But what support systems and treatments are available?
So I would say at least support systems, I think we as women in the community need to be more open to have conversations with friends and family members. You can actually find support systems. I'll be truthful with you, I'd have to do more research and we have them locally, but I know I've had some patients talk to me that they can join online forums for support groups to, with women who are going through the same thing, to have discussions. And then also to rely on our colleagues like Dr. DeVita knows and Dr. Johnson Dames, psychiatrists, psychologists, to say, this is a major life shift. Even if it's not necessarily someone who had a history of anxiety or depression, you're also going through a major life change to realize that you can never have kids again, right? And then it's a realization of you getting older. I think a lot of that plays a part in it too. But then you might say, okay, well, even if you're already doing hormonal-based therapies and you're not really seeing a change in that, then maybe we should still consider things like Paxil or paroxetine, which is that only FDA-approved low dose as an alternate option, but maybe at the regular dosing to also help apart from the counseling. Yeah. But I would say, I think there needs to be more discussions in the community to lean on each other for support. Yeah. But I also put a little caveat there that we have to be careful of misinformation, as with anything.
Yeah, the WhatsApp news network can get things confuddled sometimes.
Most definitely.
I would like to just mention here, though, I've been doing conversations in this space for a couple of years now. And one of the things that I want to point out, because I feel like sometimes people, when they hear, if I'm seeing you, but then I need to see, so for a woman, my OB, but then you're saying I may also need to see someone in either the psychiatry or psychology space. Right. I would hope conversations like this kind of explain why there's a need for that multidisciplinary approach. It's not just because people are just out there trying to take your money. It's like sometimes you really have complicated and complex things, or just things that exist in multiple spaces. Sure. And you want to have people who are, trained and experienced in each of those spaces, handling the different components of it.
I agree with you completely in that since I've come home from training, there still is a pretty large culture here at home for us that people are afraid when, a specialist is being brought into the mix or another physician. And like you said, it's almost like, well, why is that necessary? But the problem is if we are waiting until the house is burning down and the wheels are falling off to finally call for their help, that's not what it should be.
Right.
Whereas you rightfully said, I am not a psychiatrist or a psychologist. I'm not an OBGYN.
Mm-hmm.
So there are going to be aspects of the care that my colleagues who have done extra training in that specialization can really lend to us to say,
right.
okay, this is what the FDA has approved, right? And even when FDA approves medications, if it's not the original indication, we then need more clinical experience to say how well this is really going to work.
Right.
So I'm happy you say that because it is true that a lot of people, when they hear that possibility, one, they might feel like you're kind of punting them off to somebody else.
Right.
They could feel that way. And and I always tell patients, it's not that I don't want you to feel still supported by me. It's just sometimes we need that extra help. I'm not going to pretend that I do that on a daily basis because I don't. You know?
Yeah. Yeah, because that's a helpful kind of explainer there as well. So, you know, we talked a lot about hormones, how the hormone levels change, how all of that kind of goes through that process. You know, ideally, how often should women monitor their hormonal levels? And then are there any specific or particular tests that are recommended?
So I would say the time that we consider hormonal testing is all clinical based.
Okay.
In that, again, if you have a woman around typical age going through menopause and no other suggestion of other ongoing medical issues that can also lead to a cessation of menstrual cycle, then we take it as it is. However, I will often still do a pregnancy test because, again, it could always happen, right?
Just gotta be sure.
Exactly. Versus if you have someone who is younger than typical age, younger than 40 for sure, if they're in that premature ovarian failure, or someone who's having irregular periods in their 20s and their 30s and they think they may have PCOS. So for us as endocrinologists, anytime we're going to order a test, I have to already have in my mind, what do I expect that result to be? I see you as a patient, you have irregular periods, you have excess hair growth. I think you have PCOS, right? But then that's why I'm ordering the test, as opposed to just a blanketing ordering, at least in this instance. I wouldn't.
Understood.
Yeah.
So for our listeners, the clinical presentation is basically just what you see, all of the factors that you can see when a patient walks into your room, without necessarily going through the testing process.
Exactly.
All right. So as we wrap up, you know, I always like to give people an opportunity to kind of speak to, you know, the myths or misconceptions that may exist about a particular topic. So is there anything common, especially in our space, that people have as myths or misconceptions about hormonal health that you would like to debunk?
Oh, that's a can of worms. I want to say it this way, in that there is a lot of misinformation. And I'm not a big TikToker, to be truthful with you. I'm a YouTube short girl, which I think often comes from TikTok too anyway.
Right.
That you'll see people, you know, these discussions about adrenal fatigue and things that don't actually exist. So I just want to put it out there that whenever patients are considering that they may have a hormonal imbalance, whether it be female related or not, be open to the fact that what you are reading or listening to online may not be accurate. Get as much information if you feel, and then have the discussion with a physician to say, look, I'm worried that this could be that. But be open to the fact that it may not be a hormonally based issue. I would say myths to debunk otherwise is that testing for hormonal imbalances has to be done at a particular time of day and a particular time of the cycle. So again, we're talking about female sex hormones. If I have a patient who's having irregular cycles and I want more information, ideally I want to test them when they're fasting in the first through third day of their menstrual bleeding. So if, let's say, they saw their primary doc and their primary doctor said, hey, go do all these labs. They didn't care if they fasted. They did it in the middle of the day. It's not going to be as helpful.
Right.
And a lot of this testing is expensive, especially for female hormone testing. It's not as simple as thyroid function, hemoglobin A1C we talked about with diabetes. Those tests can still be fairly costly, but nothing in comparison to this. So I would say, again, for us as endocrinologists, it's always, okay, this is what you are feeling. This is how you appear. These are all the pieces of information. Now, what do we check? What do we think is really happening?
you only get to the testing when there's a significant suspicion of something. So that way,
Correct.
like you said, because the cost sometimes can be so high, you want to make sure you're not having people doing tests just because they do the test.
Correct. I mean, don't get me wrong, there will be some patients that will say, Doc, I don't care. Like, I want to do this.
Right.
And then in that instance, I'll tell them, look, I think my overall suspicion of you having this condition is low.
Mm-hmm.
However, if this will help you to feel reassured, then we'll check it.
Right. Sometimes people, it is that, right? You're looking for reassurance because you think there may be something going on.
Right.
And you want to get that extra layer of information.
Mm-hmm.
All right. So my last question for you, what advice would you give to someone who suspects that they may have an imbalance?
I would say do your best to describe and understand what you're feeling, what is happening, how long it's been going on for, and come to see me or one of my colleagues and we can help you try and understand. Even if you start with your primary doctor, that's still a great place to start, but try to get as much information so you can really explain to them how you're feeling.
Right.
The reason I say that is if someone sits down in front of me and just says, Doc, I think my hormones are off, we got to delve deeper. You and I are going to have a full discussion about what does that mean for you. In that there are so many hormones, right? We talked about thyroid, we talked about adrenal, we're talking about sex hormones right now, but then we have to think about insulin and glucagon and, vasopressin, growth hormone, all of these different hormones that exist in our body. We have to pinpoint where we really think the issue exists. So I would say when trying to get the best outcome for a patient, advocate for yourself and try to have as much data. Even if you think it's a minuscule detail, for me as an endocrinologist, I want to know it. And then I might tell you, hey, that's all right. I didn't need to, that doesn't necessarily change it, but it's better to have more than less information.
Gotcha. All right. So how can people get in contact with you if they wanted to book an appointment?
Sure. So I am at our Collins Avenue Subspecialty Clinic, which is where the tiny shop used to be. The number there is 605-2030 or 605-2031. I'm there every day of the week except Wednesdays. Wednesdays I'm at our East Street South location. But if they're feeling they need help, they want to sit and talk, or they want to try to understand could they be having a hormonal imbalance, let's sit and chat.
Okay, awesome. Thank you so much for taking time out of your busy schedule. A lot is going on.
Yes.
So I want to thank you for taking time again out of your schedule to join us today and talk through this conversation.
Thank you for having me again. I appreciate it.
Awesome. Thank you for joining us for today's episode of Vital Voices. A big thanks to our endocrinologist, Dr. Carmen Cartwright, for shedding light on the complexities of women's hormonal health. Remember, knowledge is power. Don't hesitate to seek help or ask questions about your health journey. And be sure to tune into our next episode. We'd also like to give a special thank you to today's sponsors, Oak Tree Medical Center, Colina Insurance Limited, and Valor Security.